Hello, myself Sandeep. I'm the nursing coordinator in the BMGH Sankalp Center for Pediatric Hematology and Oncology BMT. Today, I'm going to talk regarding the central line management and maintenance by the nursing. So central line management in the nursing, in the bone marrow transplantation is a very important part, the procedure. For the success of the bone marrow transplant unit, how important is the condition regimen and also cell dose. The management of the central line is very important for the success and rejection of the patient. So whenever we have hit up with central line infection during the transplant, it has directly affected to the result of the transplant. So whenever patients are getting central line infection, the patient is going to into the sepsis, and the sepsis is going to affect the bone marrow engraftment. So later part, the patient will get rejected, or sometimes we may lose the patient also. So I'm going to start with my presentation. So nurses' responsibility and management in the managing the central line. So the management of central line means it's not only the central line dressing or tube changing or blood sampling. The management of the central line means from the insertion to the removal, the whole management is called as a central line management. So from the insertion to removal, in every area of the management of the central line, the nurses are going to directly involve. So as I mentioned you, from the insertion, before shifting the patient to operation theater for the central line insertion, the patient has to get the skin care. That is very important. Where in normal, in our skin flora, there is a lot of infections will be there, or microorganisms will be there. If we not clearly clean that one directly, if we send the patient to OT during the insertion time, there is a chance of getting contaminated. The standard practice now, the central line insertion day in the morning, the patient has to get the chlorhexidine based solution bath. The chlorhexidine based solution, when we use the patient from the head to foot, completely patient has to scrub the skin and take the bath in chlorhexidine based solution. Once the patient has taken chlorhexidine based bath, then the patient can be shifted to OT. The next part start, skincare is finished. The next part start, if the patients, especially for transplant patient who needs any procedures in the OT, that has to be done in the first preference. Whenever the OT has started, generally for our transplant set patients, any procedures are there, that has to be taken first. As our patients are going to become immunocompromised, also some of the patients already immunocompromised patient, there is a high chance to get infected from the OT to the patient. So whenever we prefer the first cases, so the risk of infection may be reduces. Once the patient has done the central line insertion in the OT, then the patient will be shifted back to our department after the patient recovery happened. The Hickman line is today I'm going to talk completely about the Hickman line. The Hickman line insertion will be done under the general anesthesia. So patient will have receive the general anesthesia. Patient will be in the recovery mood, and once patient will become in recovery, the patient will be shifted back to our department. Once we receive the patient, first of all, we have to see the consciousness of the stability of the patient. We have to check the vitals. However, the central line tip is not supposed to touch. Once the patient has received, the image is very important. So generally during the insertion in the OT only, from the C-arm machine, they will take images. So we have to collect that image and we have to show to our doctor to get the confirmation of the tip. If from the OT, if they have not taken the central line image, then at the bedside, we can get the normal chest X-ray, and from that X-ray we can get the confirmation. However, before accessing the central line, we have to get the confirmation from the doctor, and it has to be documented in the notes that central line can be accessed approved by the particular doctor. So once the skincare finished, OT preference finished, next tip confirmation finished. Next it comes about the pain management. As Hickman line is the tunneled procedure where patient will have the insertion injuries in this chest area. Post surgery, once the patient is recovering from the anesthesia effect, the patient may start feeling the pain. During that time, patient has to be assessed for the pain assessment, and patient has to be administered the analgesics as per the doctor order. At least 24 hours, patient has to receive the analgesics for the pain management. Generally, we are dealing with the pediatric population of patient, where after the central line insertion, patient will have the pain and patient will have some discomfort in this neck area. So there, if we not manage their pain or if we not manage their discomfort, there is a chances the patient may pull out the central line without knowing. So that is the reason we have to closely monitor and we have to manage the pain management. Next, it comes for the exit side, entry side suture removal. So for the Hickman line, there will be two sutures will be there. One suture will be there where the cuff is there, where central line tube is coming outside. That is called as a exit side, which is coming outside. The entry side, where in the neck part, there will be one insertion will be there, where the catheter are just entered to the jugular vein. So that area has been closed with the suturing during the surgery. So that is called entry side. This entry side suture has to be removed after 1 week of the post central line insertion. Next, it comes for the next management is CVL dressing. The CVL dressing has to be done next day of the insertion of the central line, and followed by every weekly once we have to do the CVL dressing. In between, if the patient has any oozing or any displacement of the tagadam, in that case, immediately the central line has to be changed. The next management comes about the ANTT technique and safe infusion practice. About this, I'm going to show you some videos how to manage it. ANTT means aseptic non-touch techniques. That's very important, where we are not supposed to touch the key areas of the central line and the administration kits. And safe infusion practices means maintaining the sterility, especially herbs, that areas where it has to be clean. We have to clean with the alcohol sub, then only we have to touch that hub. And even that hub area also, we are not supposed to, even though we are wearing the sterile gloves, sterile equipment also, we are not supposed to directly touch with our hands. So we have to maintain that ANTT with the safe infusion practice as very important, managing the central line. The next part comes about the regular connecting tube changing. So now generally we are using Hickman line single lumen. There it comes single lumen, double lumen and triple lumen. So to prevention infection, better to use for the single lumen. But in this single lumen, we will be connecting many connections. There will be a IV set will be given, patient is receiving the IV fluid, some connection will be the where antibiotic, some connection will be the where chemotherapy is getting. This all the connectivity tubes has to be changed at least 3 days once. And this is also depends on the protocol of the hospital. In as per our protocol, we will change for 3 days once. Some of the hospital, they will change weekly once. Some of the hospital, they will change 24 hours once. Some of the centers, they will change after each infusion. But if we are going to change after each infusion or 24 hours once, frequently handling of the central also may lead for infection. Next part comes in central line management is CVL patency check. So in the especially the central lines, it's very useful. The indication of the central line, especially for us, regular blood sampling, administration of blood product, administration of chemotherapy, and long-term therapies. That is how the indication where we are using for the central line. The same time, if we not properly use the central line, patient is going to get the central line infection. Also, there is a chance of getting central line block. So if we not maintain patency very well, there is a chance of getting the central line block. And I'm going to talk that also in further in the slides. The next management comes about the CVL blood sampling, where regularly we will be patient may need CBC, LFT, RFT, these things. So these all the things can be done by the central line from the Hickman line, where we are not making patient to be discomfort by direct pricks. And next part, last part about all this management insertion to till here everything, the documentation is very important. So what are the observations we are seeing in the central line, and what are the changes we are seeing? What are the patient is receiving? This everything has to be documented very clearly, and it has to be handed over to next duty staff. Also, the concerns has to be reported to doctor. For above all the management, what I mentioned about the central line management, the main thing is, including central line and infection control, the main management is hand wash, hand rub is very important. Before accessing that line and after accessing line, thorough hand washing and maintaining the sterility is very important to maintain the central line management. The next part comes about the continuation education. The education is required for the staff and patient attender. The staff education is very important, where we are going to educate the staff, especially because universally the main problem we have today is staff turnover. So in the transplant unit like us also will have frequently staff turnover. Whenever we are receiving the new staff, when the new staffs are joining with us, so thorough orientation and competencies assessment for them and education regarding the central line handling is very important. Also, continuous education for all the staff also very important to management of central line. The next part comes about the patient and attender education, because the central line is management is not for nurses, it also equally important for the attenders also, because the skin care is very important, maintaining the patient hygiene is very important. This all the thing has to be educated to patient attender how to maintain it. The lastly, I want to tell two things about the central line management is the teamwork is very important. It's a team in the nursing team. If the one person is not following what it is written in our SOP, it's going to affect all over the team. Because of one single unstable method, it gives infection to patient, where patient is going to suffer, patient is going to become critical, patient is going to have a lot of antibiotic. Habitually, this is going to lead pressure on nursing team, where the workload will increase. Patient may need one-to-one care, antibiotic, everything is going to increase the workload. So here, main management of central line, the teamwork is very important. Next thing is comes doing the right thing when no one is looking, especially night shift when the supervisors are not there in that moment when I'm handling the central line. I want to, even though nobody is looking at me, I have to make sure to follow the SOP what is written. For this, all the management, the standard operation procedures are very important. How we are going to manage central line in our department. The next slide, I'm going to talk regarding the CVL dressing. So as I mentioned in previous slide, the CVL dressing will be done next day after the insertion and once a week. But in each shift, the nurses has to be observe, inspect the site surrounding area for the pain, swelling, brushing, erythema or exudate. If anything symptoms are oozing or displacement of the dressing is tagadam is there, means immediately it has to be changed. If anything exudate present, remove crusting gently with NS soak gauze. Any that white patches, white thing, something is there, means it has to be clean with the NS gauze. Present, the standard solution is using for central line dressing is chlorhexidine based central line dressing. Some of the centers are using betadine, some other solution, but the standard solution the presently is using is the this one, chlorhexidine. The dressing, chlorhexidine solution is very important. And whenever I am doing the dressing has to be start from the circular motion from exit side to outwards. That is inner to outer, where less contamination to higher contamination. I cannot do from outer to inner. If we are going to do outer to inner, we are going to bring highest contamination infection to the exit side. So always start with the exit side, inner to outer circular movement. So once the one gauze piece has been used, clean that area, that has to be discarded and that has to be used with the new gauze piece. That is very important. Next thing is, once you clean with all these things and apply the tagadam. When you're applying the tagadam, make sure that has to look like this. The exit side has to be accurately center part and tagadam has to be spread equally surrounding all these areas. This is very important. If anything, after the chlorhexidine applying, before sticking the tagadam, at least you have to give time for 30 seconds. The chlorhexidine action will start once it completely dry. So after cleaning with chlorhexidine, allow this skin area with this catheter area completely dry. Don't wipe with the gauze or anything, don't clean. It has to completely dry itself. It will take approximately 30 seconds to dry. Once it dries completely, then apply the tagadam in that area. If anything, patient has the chlorhexidine reactions in the skin, rashes will happen after using chlorhexidine. Such type of things, if you are going to find out, you can use alternate solution as a normal saline. You can clean with a normal saline. If the any from the exit side, if anything oozing or pus, anything, if you are observed before doing the dressing only, before cleaning that area, take the swab, take the culture from swab, and we have to send the culture for that thing and document it. The main thing is important thing, this exit side has to be always in a dry situation. It should not be wet. If the wet is there, the infection is going to start from their area. Other important parts are, whenever we are doing dressing, we have to use the mask, because as we are closely, we are going to be with the patient. From our mouth, the contamination should not reach to this central area. Also, for patient, we have to ask the patient to turn the head for other side. Patient own breathing also should not affect, go to that area to get contamination. If patient has anything, cough or cold, running nose, anything, better ask patient also to wear the mask during the central and dressing. So these are the important part. As I mentioned you, once a week we have to do, next day we have to do. If anything oozing or anything is there, immediately next we have to change. And chlorhexidine is the standard solution which we are using for central line. Allow it to completely dry. Once it dry happen, tagadam has to be applied like this. If anything exit side oozing or any blood bleeding is there, we can use a small piece of gauze piece in this area to observe that bleeding. If no bleeding, nothing is there, means no need of using any gauze piece. It has to be completely open, which will be very helpful to observe what is happening in that area. Here I am going to play few videos where about the ANTT technique. So ANTT technique means aseptic non-touch technique. This is very important in the transplant setup, where we have to maintain the key areas has to be very sterile. So what we saw that ANTT techniques is, so especially the key areas where tip of the syringe, tip of the IV set, so three-way connector tips, these are the things we are not supposed to directly touch that areas. That areas we have to maintain the space in between where directly we are not supposed to touch that areas. That is very important. And also, I'm going to show you one more video where safe infusion practices are going to happen. Once more, I play this video is not played fully. First step is performing the hand wash is very important. Second step is make the center line accessible easily. Third, again, perform the hand hygiene. Wear sterile. Fourth is wear sterile gloves. The sterility may has to be maintained. The fifth one is scrub the hub. So this is very important. This is all the key areas where these connectors are there. That has to be used. We have to use the alcohol soap, and clearly we have to clean that one. At least 15 to 20 seconds, we have to clean that area. Then only we have to administer required medication. During administration time also, we are not supposed to touch the key areas. Pushback method has to be used. Once the medication is administration, re-scrub that area with alcohol soap, close the wrap, and discard all the items. So this is the safe infusion practice, which is very important to maintain the sterility of the lines. So as we saw, CVL dressing we saw, ANTT technique we saw, where the key areas we are not supposed to touch directly. Next we saw safe infusion practice, where scrub the hub, clean the hub before using the procedure, after using the procedure. Next thing I want to talk about the regular tube changing. As I mentioned before, we are, as per our policy, we are changing all the connections which is connected to the center line 3 days once. What are the connection? That is IV set, extension connections, microclave connector. This all the thing 3 days once completely we have to discard. We are going to connect the new one. So before connecting the medication, before doing the connecting the tube, priming the tube is very important. So otherwise the air will enter. With the sterile method, we use the sterile wrap, sterile gloves with the gauze, everything. Completely prime the tubing. All the tubings has to be primed thoroughly. Air should not be there inside. Once the tubings, everything has thoroughly primed, we have to use the microclave connector just before connecting to center line. This microclave connector is going to act like it is going to prevent backflow. If anything by mistake this area disconnected also, the blood will not come backflow. And also it's going to prevent the infection. Directly we're not going to touch the center line. This area we're going to clean and use. Next thing is, once the tube, everything is connected for the patient, all the connecting area, this central and connecting area, this area, and this three-way connecting area, IV set connecting area has to be closed with the sterile gauze or sterile wrap, and it has to be taped. That is very important. It has to be not in open. For all these procedures, ANTT techniques are very important. Maintain all this. These are the key areas where this connection and this three-way connection, IV set connection, these are all the key areas. Even though we are using the sterile gloves, we are not supposed to touch that area. And next thing is daily in the nursing shift, they have to observe all these connection areas, is everything. If anything damage or leakage from area, immediately fluid has to be stopped, complete tube has to be changed and informed to doctor. The next part comes about the CVL patency check. The CVL patency checks, as I mentioned in the previous thing, is very important. The indication is for the CVL insertion, how important. Similarly, the maintaining also very important. If you not maintain patency well, there's a high chance to central line to get blocked. Once the block happened during the patient transplant situation, it will become very difficult to manage the central patient. So how to prevent it? So if you're using central line for medication purpose or anything, better run the fluid continue 5 to 10 ml per hour, low amount, where it will make sure the fluid will be running, the central line will be getting used. If really patient don't have any IV medication, then if you want to stop the line, then we can use the hep lock. Always when you're doing the hep lock, make sure to maintain the positive pressure. So how to maintain the positive pressure? If you have the 2.5 ml of the heparin hep lock in your hand, means when you're pushing inside, slowly you have to push. When you reach nearly 2 ml, clamp the central line. So you're not supposed to completely push inside. Once you completely push inside, the negative pressure will create, the blood will come back and block will happen. No use of doing heparin. If you want to do effective hep lock, maintain the positive pressure inside, push 1.8 to 1.9 or 2 ml, remaining 0.23 ml, may save in that syringe only. That situation only immediately clamp the central line. So then it will maintain the positive pressure. Some of the centers also use antibiotic locks, which will be useful for the maintaining the infection preventions. Always when you're using the central line syringes, always use the 10 ml syringe. If we use smaller syringes, there will be a high pressure where the central line inside walls may get rupture and damage will happen. If we use very bigger syringes also, pressure will be less, we cannot push properly. So 10 ml syringe is the standard syringes, which will be very good for using the central line. And hep lock also, don't prepare yourself by NS and mixing that everything do. So now in the market, the prepared hep locks are available. That is the better thing to use. Otherwise, if we are going to prepare ourselves with hep lock with the normal syringe, heparin and everything, there is a high chance to get the patient infections. This is about the patency check. And next thing, it comes about the CVL blood sampling. So this is also one of the indication where to insert the central line who has the regular blood sampling. Such type of patient need the Hickman lines, central lines. So whenever the doctor asks you to do some sampling, first of all, make sure collect all the articles, required tubes, everything, and make sure how much ml you're going to draw the blood. That is very important, because now if you want 10 ml of blood, if you draw 8 ml, again, if you want to do that 2 more ml, frequently we are not supposed to touch the central line. So before the procedure, clean the hand and maintain the ANTT techniques. If any infusions are going on, any fluids are going on, first of all, make sure to stop that fluid and clamp this central line. We have to stop the IV fluid and clamp that area. And open all the wraps, do hand wash, and disconnect the infusion set. Infusion connecting what is connected to this central line, disconnect that area, and connect for blood sampling purpose, you should have the 3 syringes. So one syringe, first syringe which you're going to connect, you're going to withdraw 3 to 4 ml of blood, which can be used, that is called as a discard sample. That sample we are not supposed to send for blood test. That sample can be used for the blood culture or the blood grouping. Again, after collecting the discard sample, disconnect that syringe and connect the new syringe. In that new syringe, take the required amount of the blood and again disconnect that syringe, and you should have third syringe should have the normal saline or sterile water. So normal saline has to be flushed that line. Clearly, there should not be any clot in this area. If you find any clot or any blood rash in this area, change the Q set. Otherwise, if everything is clear, clean with the spirit sap. So before connecting the syringe, after disconnecting the syringe, this area has to be completely clean with the spirit sap. When you're cleaning with the spirit sap, you're not supposed to touch the inner part of the spirit sap, where it is connecting, where it's getting touched with the these connections. That has to be clean completely. Then connect the regular tubings and release the clamp. So this is very important. If the patient don't have any IV fluid, in that case, again do the heparinase that line, block the line and cover this area. So this is regarding the importance of the blood sampling. However, the blood sampling, when we are doing, we have to talk with our doctor. So daily, many times, as per my experience, the requirement of daily sampling is no need in our transplant setup. At least 2 to 3 days once we can do the sampling. How much we are minimizing the blood sampling or touching that center line, that is going to help us to prevent the infections. The next topic is about the thrombosis of the line. So generally, first of all, the central line should not get thrombosed. The prevention is very important. How to prevent it? We have to maintain positive pressure, as I mentioned you, during the epilogue. Second part is very important, infusion pump alarms. Whenever pumps are getting alarm, whenever the central line get anything blocked or anything inside issue, clamped, anything issues there, monitor gives the very clear alarm up. It will mention occlusion. So whenever you see occlusion alarms, immediately take into attention, attend that patient. Make sure all the flows are going on. If frequently occlusion alarms are happening, disconnect the center line, flush that line, see any problem is there. The next part is continuation infusion. So continuing the infusion, or if not using the line, block the line. Third part is generally what we have seen during the blood product administration, because of the solution is thick solution, there is a high chance to get the blocks. So now, if the block has happened, the central line has got blocked, how to deal that one? So immediately stop the infusion, clamp the line. Next, with the sterile way, maintain all the ADT technique, disconnect that line and clean with the alcohol swab and connect the 10 ml syringe. With the 10 ml syringe, just gently aspirate that line. Aspirate, slowly aspirate. If the backflow is not coming, just you can use the HEPLOC also. Just slowly push back method. We are not supposed to directly push forcefully. Just do pushback method and withdraw and see. If that is not get success, with the doctor advice, inform to doctor and get a advice from them, and we can use the urokinase. If we are going to use the urokinase, first of all, we have to make sure our patients are high, always the platelets will be low. There's a high risk to get the bleedings. We are not supposed to forcefully push the urokinase inside. Gently do the push and pull method and slowly inject the urokinase slowly inside. Once the urokinase inject inside, clamp that central line and allow for the 30 minutes. Maximum we can wait for 2 hours also. That line has to be labeled as a urokinase has been installed, and that line is not used for any purpose. After 30 minutes, after 2 hours, reopen the release the clamp, sterile way again, maintain all sterilely, withdraw and see the line with the twist, push and twisting method. If the backflow starts coming up, at least withdraw for the 5 ml, completely urokinase has to come outside. Then that line has to be flushed with normal saline. If the procedure goes not success, in that case, Inform to doctor, and disconnect the syringes, everything, clamp and label and keep that one. Take a medical advice. Next part comes about the CVL damage or misplacement. So these are the one of the major problem what we see: cut, puncture, leakage, or accidental removal. So sometimes the patient will have discomfort, disoriented, patient may pull out, it may get cutted. Or sometimes the staff, what they will do is the gauze piece which we have connected here, micropore, what we have connected, if it's too tight, staff will use some sharp blade or scissors to cut that one. We are not supposed to use any scissor or sharp item near the center line. Because if it's cutted means we cannot do anything. Later we have to remove that. So anything leakage or accidentally patient removed out, so immediately that has to be taken care very well. If anything cut happened like this, so immediately clamp. If the clamp is part outside, clamp is not inside this area, in that situation, CVC has to be clamped in the proximal area, which is near to patient. The clamp can be used as a normal artery forceps. We can use this artery forceps, close this catheter and clamp that area. So whenever, if you see any damage, central and cut everything, don't become panic. If you become panic and if you not attend this area, suddenly all the blood from the heart comes outside and we may lose the patient may go to hypovolemia. If that happened, immediately clamp that area and seek the medical help. Inform to doctor, inform to co-staff and take a medical help. That is very important. Next part is about the CVL removal. The criteria for CVL removal, maintaining of the platelet counts are very important. Second thing is the not transfusion. Patient should not dependent on platelet. That is one of the, when discharging, we are doing the CVL removal. Next thing is whenever patient has the infections, then patient CVL has to be removed out. Because in the transplant setup, CVL infection is the one of the dangerous sepsis which we may lose the patient. So whenever we are suspecting the central line, if the patient is going to sepsis, immediately remove the central lines. Next thing is, if anything blocked thrombus happen, no option. If we tried with urokinase not work, then line has to be removed. Last part is any damage or misplace happen, cut anything happen, that line has to be removed. How the procedure for removal? If you're going to remove the CVL, if the suspecting of infection, if we are removing means that tip of the center line has to be sent for the culture. If no infection, then no need of sending that tip for culture. Again, follow your hospital policy. Next thing is, in the exit side, we have to apply the pressure bandage and keep pressure on at least 20 to 30 minutes. And patient has to be in a lie down position for 30 minutes. And patient has to be observed vitals, everything. Watch for oozing, any bleeding is there. This is one of the paper which we have wrote, comparing study between the two centers. CVL removal, generally many centers, they will do in a short anesthesia or general anesthesia. In our center, we have the huge patients whom we have removed with the local anesthesia at the bedside. We have not shifted the patient to OT or any procedure room. In the bedside, we have done the removal with the local anesthesia and patient has discharged immediately after observation of 30 minutes. Even the central line has been removed in our centers in the OPD and daycare setup also. The documentations are very important in managing central line. So daily staff has to check the CVL assessment, any bleeding, any oozing, any swelling is there, any exudate is there, anything is there, it has to be observed and it has to document thoroughly and has to be informed to concerned doctors. And tracking of the central line dressing, tube changing, hep lock, this all the thing has to be documented thoroughly in nursing notes. And any cultures has been sent from the site. Also, patient isn't any antibiotic for the central line purpose. So these all the things has to be documented thoroughly and it has to be part of the handover. Here few format I have mentioned where CVL side assessment finding documentation. This is called central line maintaining the bundles, where we have to document any erythema is there, swelling is there, any discharges are there, any phlebitic symptoms are there, any block was there, fever is there during the central line patient, and length of how long patient has central line is there, Are we using any tube TPNs, total parental nutritions, and when was the last dressing was there, and anything is there. If anything remarks, we can have to mention here. Similarly, 3 format I have used. So this is going to help us to closely monitor what is happening with the central lines. Till now, what I have spoken, all this as a nursing management for the central line. And also here are few images I have mentioned where types of central line. Catheter infection. This purely will happen handling of the central line. If we not maintain NTT technique and safe infusion practice sterility, the infections are entering into the catheter where directly it will go to bloodstream, patient will become very sick. The next infection is tunnel infection, where you can see here the red line, we can see the infection. The next is exit site infection, where the pus or discharges will come in this one. All the observations are very important to observe by nurses and document and inform to doctor. If you see any exit site infection, slowly to start tunnel area. So whenever you are observing central line area, observe the exit side, any these areas are there. Also observe any touch and feel here. Patient is complaining of any pain in tunnel area. If anything in complaining of patients have pain or anything, immediately inform to doctor and take necessary actions. So overall conclusion, the central line management is not only for dressing or tube changing. It's from the insertion, skin care insertion to the removal. All this management, somehow the nurses are involved somewhere directly or indirectly. So managing the central line, many areas the nurses are directly involved: dressing, tube changing, blood sampling, this all the thing. However, how much we are going to minimize the touching of the central line is very good option. If we don't have any work with central line, don't touch the central line. If really needed, think, if I'm going to test the central line, we have to follow our standard operating procedure. Maintain A&D technique, safe infusion practice, clean that everything. So managing the team is very important. Education for nursing team and explaining the importance of central line education and education to attenders. This is also very important. Finally, the important role is hand wash. All these procedures what I talked till now, hand wash and hand rub is very important to maintain the sterility of the central line. Thank you very much.